Hello and welcome to the Scopewell podcast. My name is James Luthi. Today, we're going to talk about what it takes to lead finance in a public health system under historic pressure and what one leader is doing to redesign the function from the inside out. Joining me is Sham Firdausi, Deputy Chief Financial Officer of the County of Santa Clara Health System. Sham, thank you so much for joining me today.
Thanks for having me.
Sham, you have a military background, $140 billion health plan on your resume, and now you're running finance for one of the largest public health systems in the country. Give listeners the background of how you got here.
Yeah, that's a great question. I didn't start out that way. I was born overseas, in Pakistan, single mom. She always had this one thing, you see things that are broken, you fix it. Was big on education, and she decided to, pursue the American dream, which every, immigrant family does. You want to come here, make your life better, make your children's life better. So she brought myself and my sister here, grew up in the Chicagoland area. And that was always kind of the mentality as growing up, you see things that are broken, you fix it. Unfortunately, she passed, and then we kind of had to just run around and do our thing. And that's when I saw the broken healthcare system, having to deal with it, having to see the public health, safety and health system and how disjointed, not just even that area, just how disjointed the American healthcare system is. Joined the military, Marines, then Army, deployed to Iraq with the 101st Airborne, that unfortunately got injured, and really had to think about, what's going to continue me to continue to serve the people and serve, in that way. So I decided, I'm like, well, the healthcare system is broken. I can't just understand one area. I have to learn it all. Started my journey, United Health Group, the Optum side, learned the revenue cycle systems in and out for the Optum 360, how that works. Went back, worked on the provider side in Northwestern, continued to learn, even to the tune of, doing the PBM stuff for 340B at CVS. Took it all in, became a CFO for a regional health system. It was a private equity, for-profit health system, part of LifePoint Scion Health. But wanted to continue to make my way back into public health safety net that gave it all. And that brought me here, County of Santa Clara Health System, being a 33-year-old and at the helm of making these transformational changes is a challenge in its own. But given the time pressure and crunch we're in, I'm very excited. And I really chose to be here to really make an impact and change the trajectory of where our health system is headed.
Sham, thank you so much for that background. Most CFOs at large health systems come up through accounting and corporate finance. You came up through operations and the payer side. How does that affect how you see your role?
Both backgrounds have their, ups and downs. For me, I am very much of a person that loves to learn operations and business, because it's harder to make a decision financially that impacts others' lives when you don't know what they do day to day. And that's the important of it. When I have an MBA in accounting, and I did it just to kind of, for me, it was like a check in the box on the accounting side of the side, or learn the foundation, which is, everybody should have that foundation if you're working in finance. But at the same time, I was never the person that's like, hey, accounting this and accounting that. For me, when I think about accounting, it's something that's done today, and it's like, what we got to do in the past. To think about the future, to think about the trajectory, it's really important to understand operations, financial planning, and kind of the payer side of things. So for me, that was really important. Every decision I made, I'd like to involve clinical leaders, operational leaders. When I was in the regional health system, I would spend a week in one of the different areas, from women's health to registration, to sitting up front with registration, sometimes scrubbing in and watching the clinicians when they would have people over to invite and see things happening. So then I can understand the gaps in the processes. And then when I'm making financial decisions, I keep that in the back of my mind. And that's how I'm training the future generation of finance leaders, because finance and operations now are just so combined. And, the future CFOs have a big challenge ahead of them, right? Either they really stick to those roots in finance and accounting and just kind of get left behind in the past, or they think about operations, they think about strategy, and really have a seat at the table in being able to make some of those decisions.
The County of Santa Clara is staring down a nearly $1 billion funding shortfall by 2028. Help listeners understand what that number actually means, not just for the balance sheet, but for the people who walk through your doors.
Yes, I mean, it's an unfortunate situation. As we know, across the country, there's about almost close to $1 trillion cuts happening in healthcare. For a system like County of Santa Clara Health System, we have 4 hospitals, clinics all spread throughout the county. Even though we're in the heart of Silicon Valley, we are a safety net health system. Our job is to take care of every single person that walks in through the door. We're going to provide care no matter what. It's not like some other health systems. We don't have the luxury to pick and choose our patients. And that's no shade to other health systems. That's just how things work in the healthcare world. But for us, that's important. A lot of our funding is, we do have a heavy Medicaid population, Medicare population. A lot of our funding is some of the DISH population, and that's been impacted. So we're staring down a barrel for $1 billion. And for us, we can't still turn away patients. So even if patients get disenrolled in Medicaid and they're still going to come and get care here, which is needed. So for us, that's a challenge, which, me and my team and the leadership at the county, we're all working through, but we cannot turn our backs on the people, especially given the time and the environment we're in, and turn our doors away. So we're going to keep our services up and running. We're just going to have to really think through where we bring in more revenue through the door, maybe think through how we can make some operational changes, better efficiency, really think through different strategies, and also start thinking like how other health systems do. And, counties have always had this reputation that, yeah, true, we do provide care to every single person that walks in the door, but at the same time, we do need to be able to bring in some dollars as well. So we have to get creative. Again, unfortunate situation, but that doesn't mean we walk away from our mission. We double down on it.
So you've been in the role about 8 months. What surprised you most when you walked into it? And not just the federal policy headwinds you alluded to, but internally as well.
Yes. County health systems, I work for nonprofit hospital systems. I work for the private sector. This is a beast of its own. I mean, there's just a lot to learn because, you're part of the county. So there's obviously the balances that you have to understand the county area as well, right? Because it's not just the healthcare impact. These are taxpayer dollars, right? Similar to other nonprofits, but here, truly, these are a lot of that. We're bringing revenue in the door, but some of it does impact and come through some taxpayer dollars, and we have to be mindful of that. I think one of the things that really actually surprised me, for me, even myself growing up, using the safety net system, as I mentioned, Cook County Health in Chicago was my lifeline, my sister's lifeline growing up. I always thought of it as like, oh my God, it's a public health safety net. But when I came here, and I think that's one thing I didn't never notice, is we are way ahead of some of the other hospitals that I've worked at, some even private equity. I mean, we train, I think I can't think of the exact number, but I know public health safety net hospitals in California are like 5 or 6% of the total health system, but they train almost close to 40-50% of providers. So we're building the foundation for the providers. We're running Stanford's residency program. So, when other health systems look at what they're doing, it all starts here. And the foundation is built in our county, in our health system. And those are the things I'm like, wow, that's exciting. But at the same time, I think that's where my head is at. If now I'm working here and I see the great things that we do, which I wasn't able to see from the other side. Now that I'm working here, like, we have a lot of things we can do. That's the image I'm looking to change across the county, across the country, that public health safety net systems aren't and can go toe to toe with some of the other larger health systems. And where I'm excited to be here to make that change happen.
I want to talk about some of the other stuff you're doing. You're doing something structurally different with how finance operates, embedding finance business partners directly into each facility and service line. Walk me through what that model looks like on the ground and what problem it's actually solving.
Yeah, exactly. So again, this is not something novel. I know other health systems do it, but the goal here really is we still have a shared kind of model where we have shared finance and shared accounting, kind of a shared revenue cycle team. We still have that structure, but the goal really is to embed a finance lead or a finance business partner as a partner to the executive leaders in each one of the facility and then across our ambulatory areas. The reason for that is to make sure we don't have any silos between finance and operations. That's important. That's key given the pressure and the financial challenges we are, not just here, but across the health system in the country. And it also helps me develop future finance leaders. As I said, if finance can understand operations and operations sees finance as a true strategic partner to them, it goes a long way because there aren't any silos. When I first came into the health system after the military, everybody I worked with across all organizations, people were scared to have finance in the room. Because when they see finance come, like, oh my God, here we go with the financial conversation. Here we go. What's happening now? Budget, cuts. But that's not what it is. The goal is really for, us to break down those silos and have the right voices at the table so people can understand them. And I think that's a model that's going to, pay dividends, for people's careers, to growth, the cross-training opportunities for years to come.
I think healthcare is the ultimate team sport, but so much of it is siloed. And it's something I hear over and again as I talk to leaders. So what does it take in to bring finance and clinical together? And has there been a moment where they were maybe looking at the same problem and genuinely saw it differently?
Yes, I mean, there's plenty of examples. I think, clinical leaders and, providers, some of the smartest people. I mean, anybody, all people working all across the hospital system, some of the smartest people. But I feel like most of the time, including finance, we've always, for the longest time, had that a very narrow vision. Like, this is our role. This is what we're here to do. Everybody was hesitant to ask questions. Everybody was hesitant to, like, hey, we don't want to step on each other's toes because they're clinical, so they know that stuff. That's true, but at the same time, what the clinical leaders know how to work with vendors and what vendors tell them, that might not be a full story. And I think that's where we're starting to realize how we can partner better with our providers. But you have vendors that come into the operating rooms that work very closely with providers that are like, hey, our product is the best. I'll give you an example. You're going to get reimbursement for it. But when I have finance team on the ground and they go back and check, be like, hey, true, but that you are going to get reimbursement, but now it's going to take away some sort of reimbursement from another area because the procedure as a whole is getting reimbursed. So adding on that supply that the vendor is trying to sell you may be great, but it might actually just chip away at the low margin that you already have. I mean, these are the conversations we're having in real time. Obviously for us, it's always patient safety, patient care comes first. So, but having that financial visibility is giving us a really good look across the system. I mean, I have providers talking to us. I have executive leaders saying how finance has just changed in the few short months we've here. It was the same as my last hospital. As I was leaving, and I told them, I took on this opportunity to take on this challenge to come here, all the way from nurses to front end staff, like because I was so involved in the health system there, talking to people, talking in front. They were very sad because they knew there was a different vision for the finance team and how we partnered together.
Yeah, one thing you're doing is you're asking finance people to think more like operators and technologists. That's a different hire and a different development path. How do you actually build a team to do that?
Yeah, I think for here, for the county, I mean, even if I was anywhere else, I think it's really showing people the vision of it, right? In the age of AI and technology, what sets people apart are those soft skills and the willingness to learn. And I think that's what's really helping me build the team. It was a little bit challenging back in the day because everybody's like, well, no, finance and this and that operation we're going to have. But here now you're seeing the pressure in the job market when it comes to AI and technology. What I'm doing is I'm upskilling people. I'm making sure people have the right skill set to have a seat at the table and ask the right question, but then also really think through people. In the age of, actually saying, in the age of AI and technology, people be on their phones all the time. AI answering this email and AI answering that email. It's good to have those like soft skills to be a human, be in the presence, but then also think about it is okay to use technology, but how do we leverage it for the good of the people? How do we leverage it within our health system? So I think for me, when I develop people, I get them to see the big picture, think about the mission, think about what we're here to do, but then also give them a career path that's not just linear. Hey, you understand operations? My goal for next finance leaders are to be the next COOs, CEOs, right? Think through operational service line leader, but that all starts with asking the questions, being flexible and being willing to learn. And I think when people hear that, and people see like I'm all about learning new things and making things better, I think it gets people excited. And I think as leaders, we need to continue to have that excitedness and the mission forward thinking.
I think in the age of AI, things that are uniquely human are going to be more important than ever to identify and lean into. Speaking of AI, you piloted ambient AI scribing on the clinical side, and you're now moving forward AI for denial management and coding. What did the scribe pilot teach you about how to bring AI into the public health system responsibly?
Yes, yeah. So public health, I think for us, same thing, just as any other large health system, we were being very careful. The goal is really thinking through how we can help our providers up front. And I think, you can see that across the country. I mean, there's such a high burnout rate for providers all across the country. Providers are leaving. I mean, they're leaving care world because they're getting burned out. For our mission was, let's pilot it. Let's see how it helps the providers. And we've heard great feedback all across from different providers on how things are done, how it's reduced their documentation time, how it's helping them do a lot of other things they could focus on. And that's great reviews. For me, that's exactly what the goal I have and envision for my revenue cycle team. Right now, we're getting ready to think through how we incorporate AI in our denial management areas. Just think through where it's going to make the most impact. We're still early on. We are doing initial demos, meeting with the right vendors, because for me, when I think about vendors, when I think about working with, external sources, I look for long-term partnerships, right? So the goal is to look for the right people. And that's the goal of the pilot with it. We're, again, early on in the stages, but we're making great headway here. And I think the county and the county leadership, or even at the health system leadership, we're on the right track. I'm just excited for the future, what's to come, and how it's going to really help our teams get the support they need and help our teams be able to utilize the technology that's out there, so we're on par with some of the other health systems in the country.
Payers have been ahead of providers on AI for years. Are payers and providers actually moving toward real AI collaboration now, or is it still aspirational?
It's still a little bit aspirational. Pairs have always been ahead in a lot of different ways. I mean, from the lobbying they do in Washington to the amount of money they spend just in technology. I think a couple of days ago, United Health Group came out with an announcement that they're going to spend, I forgot, 1.5 billion specifically on AI, right? So in one way, I know payers are very vocal about collaborating with providers. I've been on the other side. That's not always the case, right? It's one thing to put out headlines. It's one thing to actually show up and actually take action on it. I am optimistic though, because, across the country, these are challenging times when it comes to the economy, when it comes to affordability. And I think large organizations and corporations are starting to realize that. So I think maybe that will drive, especially given the healthcare costs alone, maybe that will drive a better collaboration. I'm hopeful for it. I'm always open to working with providers for better collaboration, whether it's in data sharing, whether it's like thinking through AI tools to make it easier for our revenue cycle teams, their revenue cycle teams, right? I think it's still early on, but when one provider really steps up to the plate and starts making these type of decisions, I feel like others will come around. But right now, I just feel like they're not showing that willingness to work, because right now it's a lot of blame game. Payers are blaming like, hey, hospitals are using AI to, do this and do that. And hospitals are so early on. We're like, no, you're just denying claims using your AI. I mean, Cigna got sued a couple of years back for denying using AI. I mean, United is on the chopping block right now. So I'm happy to have these conversations with payers across the country. Let's collaborate. Let's truly make our health system better. Right now, I just feel like it's early on and no one's really willing to have that conversation.
If you hold the mission and get this model right, what does Santa Clara Health System look like in 5 years? And what does that mean for how public health systems think about finance leadership more broadly?
5 years from now, Santa Clara County is our health system is going to be the model across the country. Other health systems, I mean, I already have some other health system, CFO, CEOs reaching out, understanding what we're doing differently here, how I'm getting the team excited. Again, one of the big questions has really been why leaving a private sector at your age and coming to the county, which again, for me, it's always been the mission. But the model that we're building here, my goal is it'll be replicated across the country, because our goal is to take care of people, provide care, doesn't matter who it is, and get people the care and access they need, right? That's the goal. But how do we do it in a financially sustainable way? How do we do it right by, the people? How do we do it right by the taxpayer? That's the goal, and really making a model out of that. I mean, I hope that what we build here can be replicated across the country in public and counties and safety net health system, even larger health system. Our goal is it could be replicated across the country nationally. I see people are suffering. I mean, I've gone all the way from consulting in West Virginia hospitals to, rural Wisconsin hospital, right? That's where I'm coming from, my most recent role. I know how expensive healthcare is. I've been on the other side of it, from payer to a safety net recipient. The goal is, with these challenging times, it's time to get creative, time to come together and make it happen. That's what I'm trying to model here at the county, Santa Clara, and I hope to be able to replicate that across the country in a few years.
Well, I think that's a great note to end on. Sham, I want to thank you for your time and for what you shared today. The work you're doing at the County of Santa Clara Health System, it matters. And I think a lot of our listeners are going to walk away with a different picture of what finance leadership can look like when the stakes are this high. We appreciate you joining us on the Scope World podcast.
Thank you for having me. It was a pleasure. Take care.